Next up, Dr. Phoebe Lin from Portland, Oregon will go over fundus autofluorescence and the white dot syndromes.
Thank you very much. I have no disclosures. So fundus autofluorescence was first described by Mockamer in 1970 as pseudofluorescence that emanated from the retina before they injected fluorescein dye when they were trying to capture fluorescein angiography. And since then, we now know that the main fluorophore corresponding to retinal autofluorescence is actually from the RPE, lipofuscin and RPE. And the normal hypoautofluorescence in the fovea is due to luteal pigment that is in high concentration in the central macula. The two most common clinically used fundus autofluorescence imaging devices are SLO machines, the Spectralis, which has an excitation wavelength of 488, which is more in the blue wavelength, whereas the Optos ultra-wide field fundus autofluorescence is also SLO, but it has an excitation wavelength at 532, which is more in the green wavelength. And depending on the wavelength of laser that is used, you can sometimes gain different kinds of information. So fundus autofluorescence is actually particularly useful in the white dot syndromes because of the involvement of the outer retina and the RPE area. And you have decreased autofluorescence when you have reduction, for instance, in RPE, lipofuscin density, as well as frank loss of RPE, but also when you have increased RPE melanin content or subretinal fluid or consequences of inflammation such as subretinal fibrosis, scarring, and then finally, if you have decreased emission through to the camera due to media opacity, you can have decreased fundus autofluorescence. Whereas you have increased fundus autofluorescence in inflammatory conditions such as white dots, when you have excessive RPE lipofuscin accumulation, but also you can have increased autofluorescence when you have fluorophores both anterior and posterior to the RPE. For instance, if you have things like macrophages, which also contain lipofuscin infiltrating the outer retina, but also the choroidal vessels, which contain collagen and elastin, can also give you increased autofluorescence. And so this is a very simplistic way of thinking about how we use fundus autofluorescence for white dots and other conditions that affect the chorioretina. And this is a case of relentless placoid chorioretinitis. And if you have increased autofluorescence or hyperautofluorescence, you think of that as an active lesion. If you look at the fundus image, you can see that the atrophic and very well delineated border lesions are hypoautofluorescent, whereas the poorly delineated non-atrophic lesions are hyperautofluorescent. And this is the same patient after treatment. All the lesions are now atrophic with very distinct borders, and they're all the lesions on autofluorescence are with decreased autofluorescence. But other than this kind of very simplistic approach that you can take using autofluorescence, you actually can gain quite a bit of information from fundus autofluorescence. So this is the same patient but a different time point, and in the macula, patient with relentless placoid chorioretinitis. And you can see on the correlation between the fundus autofluorescence findings and this B-scan OCT, where you see increased autofluorescence or hyperautofluorescence that is poorly delineated and perhaps moderate in intensity, corresponding to an area of hyperreflectivity in the outer nuclear layer of the OCT, perhaps indicating something like infiltration of something in front of the RPE, such as a macrophage that contains lipofuscin that's not quite as intensely hyperautofluorescent as something like lipofuscin in the RPE. And then next to that, you have an area of decreased autofluorescence or hypoautofluorescence that corresponds to this area of increased transmission of signal through to the choroid, as you can see there, and that's probably representing an area of possible RPE cell loss. Whereas next to that, then, you have an area of very intensely hyperautofluorescent lesion, and that's bordered by this hypoautofluorescent border, so it's a jigsaw lesion that has a very intense hyperautofluorescent core, and that corresponds on OCT to this area of RPE irregularity and thickening, perhaps corresponding to increased lipofuscin within the RPE. And then next to that, you have a zone of normal autofluorescence, and that corresponds to normal or near normal EZ line and RPE on the OCT. And then finally, another area of decreased autofluorescence corresponding to increased transition on that OCT, again, possibly RPE cell loss. This is a patient after treatment, and I just want to point out this area that shows very intense or decreased autofluorescence corresponding to this area of thickening of the RPE. And on examination, you would find that this area is pigmented, and so you have increased melanin content, and that's why you have this very reduced autofluorescent signal. So that's the increased inflammation. Now, this is a 60-year-old Caucasian woman who has this very classic lesion emanating from the optic disc, as the other speakers have very nicely shown. This is probably serpiginous, block early, stain late on the fluorescein angiogram. And what's nice about fundus autofluorescence is that you get this kind of image and indication of the way the lesion spreads very clearly. But what I wanted to point out is that over time, really the kind of moderately intense areas of hyperautofluorescence corresponds to areas that change into normal fundus autofluorescence with aggressive treatment, whereas the areas of jigsaw lesions that have the very hyper-intense hyperautofluorescence with the hypoautofluorescent borders, those turn into these distinctly hypoautofluorescent lesions. So you have areas that are more sick and areas that are less sick, areas that can respond to treatment, and other areas that turn into scar. And fundus autofluorescence basically gives you all of that information, perhaps areas that are less intense being more amenable to treatment, whereas areas of very intense hyperautofluorescence with the hypoautofluorescent borders perhaps not quite as amenable to reversibility with treatment. And then a very nice description of azor by prior speakers. There's probably two modes of spread. Gas described this from the periphery in as well as from the optic nerve out, and perhaps this alludes to etiology. And so that's one thing that fundus autofluorescence can tell you, the kind of degree and direction of spread, so both centrifugal spread and centripetal spread with azor. And then with multifocal choroiditis, Hahn and Spade have shown that you can see more lesions on fundus autofluorescence than you can see with fundus photography and with examination. And also you can see the degree of progression over time much more easily or readily on fundus autofluorescence imaging. Now, this is a patient, and I'm a little bit of a lumper. This is a high myope female, and she did have bilateral lesions in the macula that were more akin to PIC. But she developed, and this has been described by Lee Jampol and others, what I think it was described as an outer retinal atrophy. I'm calling it an azor-like outer retinopathy that can occur with PIC or multifocal choroiditis. And so this patient was already on CellCept, and she had these new lesions. She didn't notice them symptomatically, these new lesions in the infranasal periphery in the right eye that showed up very readily on ultra-wide field fundus autofluorescence that you couldn't really see as easily on fundus exam or even on the fundus imaging. And the left eye was stable. And then, so that gave us an indication that perhaps we should increase her treatment, and we did. We gave her oral prednisone and switched her from CellCept to methotrexate. And you can see that the lesions infranasally have spread a little bit 1 clock hour superiorly, but the older lesions have disappeared. And again, would these have gone away on their own, or did this patient need escalation of treatment? And once she's ruled out for infectious disease, I tend towards escalation of treatment. And then 2 months later, she comes off prednisone, and it really does look good, and back to normal fundus autofluorescence in those areas of new lesions. But then 6 months later, she actually developed a new lesion in which we had to bump up her oral steroids. And then on the taper, when she tapered down to 5 milligrams, she developed these new lesions in the contralateral eye. And so that actually gave us an indication to escalate her treatment further. And now she's on Humira, and we actually gave her a boost with posterior subtenon steroids. So this is a case of birdshot, and Dr. Pepley showed really nice images on OCT and OCTA, and this is classic birdshot. She'd ruled out 4 infectious causes, and you can see that not only do the deep choroidal lesions not show up on a fundus autofluorescence, but birdshot patients actually have a high prevalence of these outer retinal lesions that do show up on fundus autofluorescence as well. In a series that we recently published, it's about 50% of birdshot patients that have outer retinal lesions in addition to these deep choroidal lesions in the periphery that are classic for birdshot. And so these outer retinal lesions are what we can follow, and this is a patient post-treatment, in this case, bilateral reticerts back in the day. So the pearls from fundus autofluorescence imaging in our white dots include that autofluorescence lesions. The pattern may give us diagnostic clues. that autofluorescence can demonstrate subclinical lesions perhaps more readily than ophthalmoscopy and also fundus photography, and perhaps even more evidently than fluorescein angiography, and it's certainly less invasive than fluorescein angiography, and that fundus autofluorescence can demonstrate the course of disease, clinical activity over time, and perhaps even guide treatment and indicate recurrence or treatment response. So what we do in our practice is we order fundus autofluorescence in our posterior uveitic entities very early and often. Thank you.